Well, welcome everyone. Today is April 21st, 2021, the day before Earth Day. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth-Hitchcock Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. You can submit your questions on Facebook Live, and we've received some questions ahead of time at our website. And my guest today, I'm very excited to have Dr. Michaela Schneiderbauer. She is Southwestern Vermont Medical Center's Director for Orthopedics. A little bit about Michaela. She received her medical degree at Ludwig Maximilians University in Munich, Germany. Her residency at, is it Basel or Basel University Hospital in Switzerland?
Awesome.
All right. And then a fellowship in joint replacement surgery and training at in orthopedic oncology at the University of Miami's Jackson Memorial Hospital in Florida. Michaela, welcome, and we're so psyched to have you.
Thank you for having me.
All right, we'll jump right in just to learn a little bit more about you. First off, how long have you been at SVMC?
A little over 2 years now.
2 years, that's great. And so where did you grow up? And then just eventually get us to how you came to SVMC maybe.
Well, I grew up in the foothills of the Alps in Bavaria on a horse farm. Yes, then, went to school there and eventually to medical school in Bavaria in Munich. Then decided to do residency in Switzerland and then came to the States first because I did sort of a medical PhD in Germany along with medical school, and I spent some time at Mayo Clinic as a postdoc in research, in medical research. And then after residency in Switzerland, I went to the University of Miami for fellowships. Eventually was asked by the University of Miami to come there as a faculty member and worked there for some years, actually 7 years in total, before I came here to SVMC in Vermont, Southwestern Vermont Medical Center.
Wow. So, I mean, it's quite ideal. Do you go back to Europe much?
If there's not a pandemic, usually, yes, I go at least once or twice a year. But like everybody else, this was not really possible. And it was a bit hard, end of last year, my father had his 80th birthday and I was not able to celebrate that with him.
Wow.
But, I'm not alone.
So, yeah, well, hopefully you can get to his 81st. Yeah. And I know you like to ski because when you first came to visit, that's one of the early things you did was go skiing here.
Yeah, no, I love the outdoors for sure. And that was one of the, certainly very good aspects of coming here to Vermont.
Yeah, that's great. So tell me, so you're an orthopedic surgeon and you did a lot of research ahead of time. Which is great. It's a good combination, sort of the cerebral aspect and then the medical practice at the bedside aspect. What appeals to you most about orthopedics?
Well, at the end of high school, I had a very hard time deciding which field of study to go into. And in Germany, it works a little differently. We go right to university. We don't have college years, but our high school is somewhat a little more extended. So you have to pretty much decide right from the get-go where you go into. And I was always enticed by science and biochemistry, physics, etc. But I also wanted to work with people, and medicine seemed to be a good combination of the two things where, you could have both aspects. And I'm not regretting that choice. And orthopedics, again, is even better because one can be a carpenter and work with the hands, but at the same time, we need a lot of knowledge and apply, the current research to what we do and how we diagnose, how we figure out what a patient's problem is. So it's a good combination. For me,
yeah, that's great.
It worked out great.
And then when you decided to go to Miami, was that a difficult transition or was it sort of like you expected?
It was actually not intended at all. I did, I was on an academic path by the University Hospital in Switzerland that I worked for, and Miami was only supposed to be a year of fellowship because Switzerland is a rather small country. It only has 7 million people. And for people that work in academia, they like, for them to go abroad at least for a year or two to get outside experience.
Mm-hmm.
So this was really the intent of me going to Miami. But then, other things happened in Miami and they made me want to stay in the US, and it had to do with, finding a partner.
Right.
So it was not really my intention to stay in the US long term, but I don't regret it.
Well, that's what happens when we travel and our lives change. Tell me a little bit, and I'm actually excited to hear your answers on these, because you and I talked about this a little bit during sort of your interview process and right when you first came. But just elaborate on what you see as the differences in medical practice and orthopedic practice specifically between Germany, Switzerland, and the United States. I always find when I read about this information, I find it fascinating, but I'm not sure I get a clear answer, when I ask those specific questions.
Well, it depends on which lenses you're putting on, right? Like, is it the lens of the doctor or the nurse, or is it the lens of the patient? And I think from a doctor perspective, sort of the way we treat patients, how we diagnose, which imaging, like do we use X-ray, MRI, etc., and at what point, or what therapies do we recommend, or what surgical procedures do we choose? What implants in orthopedics, we work a lot with, plates and screws and knee replacements, hip replacements. That is actually surprisingly similar. Those strategies and techniques are very much the same, I find. But I think the patient end is completely different. That's something I learned when I started working in Miami compared to Switzerland or Germany. Financial concerns with getting treatment or entering healthcare are a lot more prominent in the United States for patients. I have that discussion daily where people say, yeah, I know you recommend that, but I can't really afford it. Mm-hmm. And that was never a discussion in Switzerland or Germany because people don't have deductibles. They don't have any kind of high copay. And they might potentially, depends on some instances, wait for an MRI study a little longer than in the mm-hmm. US, which mm-hmm. can be an inconvenience. But the sort of financial concerns with healthcare are not something that I was familiar with before I came to the US.
Actually, you bring up something. One of the things that I think our audience hears when they learn about healthcare in other parts of the country is that there can be long waits for elective procedures. Did you experience that, especially in orthopedics?
Not in Switzerland or Germany. I hear that sometimes reported from Canada. Mm-hmm. I have friends actually in Canada that are surgeons there, and they complain about some of that.
Right.
So I think it very much depends, even I think in Canada, though, even on the province. I think it's very, that it's not one sort of model is exactly the same as another model. They're not all the same.
Right. I think it's probably like a lot of things, we hear of advantages and disadvantages. And the truth is, every location probably has advantages to over other places and then disadvantages. So cost, weight, but the medicine is pretty similar So, and then also back in your history, you did a little bit of a side thing and got an MBA, a master's in business administration. Tell us a little bit about that, and then what motivated you to do that, because it is unusual for a physician to also have an MBA.
Well, I mean, I realized after working some years, as an attending physician, that budget discussions about billing became more and more prevalent, and down to the level of what we need to document so that the financial, the institution, the health system can actually financially survive and be viable. And it is, found out my own analysis was it is a different language. The whole financial and business language is a language. And if one cannot understand the language, one doesn't really have a seat at the table.
Right.
And then, in healthcare, a lot of providers, doctors, nurses feel that the administrators and the insurance people pretty much took over and decide way more than they should maybe decide in how patients are treated. And it's hard to have a good stance when they throw terms around that then the nurses and doctors don't even know what they're talking about, and then decisions are made. So I felt it would empower me as a physician if I knew exactly what they're talking about, and I could fend better for my patients as well as the healthcare providers in that. And it was very valuable in that sense.
Well, that's remarkable. And, I can tell the audience here that Dr. Schneiderbauer has that role because she is the medical director of orthopedics, which, goes to the outpatient, there's the inpatient, there's the hospital aspect. And so it is lucky for us to have you here. And it's been great. And we have a lot of things to look forward to in the future, too. Tell the audience, especially if they're not in healthcare themselves or don't have a partner or a family member, they don't really know what happens based throughout the day. They just kind of see what they see on Grey's Anatomy or some show like that. What's your typical workday like?
Well, as a surgeon, my two main locations of work are in the outpatient office, where we see patients, evaluate them either with their chronic problems, orthopedic problems, or acute injuries, or new broken bones from the ski hill, and figure out what we need to do to make those patients better. The other location where I spend quite a bit of time is in the operating room. So that's typically separated days. It's not on the same day that I see patients in the office. And, in the operating room, we, go through more of a mechanical type of work where, it's in orthopedics, it's a bit of carpentry. And we, either fix fractures, plate and screw them together, or put like internal, we call them nails, where inside of the bone, we basically bridge the broken bone area so that we stabilize it and make it heal. Or we replace joints, or we reconstruct cruciate ligaments that people tear a lot in their knees, or we help with meniscus tears or shoulder problems with torn rotator cuffs. So that's the day in the operating room, where we come in, we check on the patient before surgeries, make sure that they're okay to go to surgery. Then, the patient gets wheeled back into the sterile area of the operating room. And with the help of anesthesia, we make sure they don't feel the surgery, which would be very not nice. And so it's a big team approach. Like, surgery is a huge teamwork. There are a lot more people maybe involved than people realize. There's an anesthesiologist, an anesthesia assistant that helps with the anesthesia, a so-called scrub tech that hands in the instruments to the surgeon in a sterile fashion. So they need to know a lot of special terminology of all the thousands of different instruments we use and implants we use. There's usually an assistant, somebody who has to hold the tissues back so that the surgeon can actually do the work and see. And then there's another nurse in the room that actually has kind of the function of a runner. Make sure if another tool is needed, they can leave the room and quickly get that, and document all the things appropriately. So yeah, it's huge teamwork. And then not to forget the nursing in the recovery room. Once patients come out of surgery, and they are not quite 100% awake, and we need to make sure that they recover well from anesthesia, that there are no problems with blood pressure, anything like that. So a lot of people involved to make it a good experience for the patient and a safe experience for the patient.
Right.
And the other location is the emergency room. We're doing call, Southern Vermont has quite a few, ski places. People are on ATVs, they ride dirt bikes, they bicycle, they hike, and injuries happen. And that's where we also spend quite a bit of time.
Yeah, so every 3 or 4 nights, you're available to come into the emergency department should one of those people, unfortunately, have an accident and need an acute procedure done by an orthopedist. So you do all that, and then how do you relax on the weekends or on an off day?
Oh, I think number one key is to avoid news. It's just a little bit of maybe dark joke. Yeah, I like to be outdoors if I can and be physically active. So if the weather allows, I'll, try to in the summer go biking, running, swimming, paddleboarding. In the winter, more on the skiing side, be it skinning up a mountain or cross country skiing. Those are more my favorite activities in the winter.
That's great. And you talked about avoiding the news, which actually I'm really glad you brought that up. It's really important for our mental health. You need to stay in touch about current events and what's going on, but we've all just overloaded ourselves, and it brings about anxiety, really. So how, in that regards, over the last year, how has the pandemic changed orthopedics and your practice in particular? What have you seen?
It was a little bit different phases, right? Like
Uh-huh.
I think when we first all realized there's a bigger problem going on in like April, maybe early May, just like most other practices, we cut back quite a bit how many patients we saw, how much appointments we did try to do via, online means, telehealth, or the phone. But in orthopedics, that kind of only goes so far, because if somebody injured their knee falling, uh, one can't really reliably assess that via the internet. Ultimately, one does need to have some hands on the knee and see where it actually hurts and if it's stable or not. And that's not easy to do, on a phone or on a Zoom meeting or DoxyMe telehealth. So relatively quickly, we felt that it was safe with the appropriate precautions, with face masks, face shields. Unfortunately, patients not accompanied, by their family members, but that we were able to resume pretty much our normal, visits in the office, and have maintained that throughout now. So at this point, I feel like we are working kind of how we worked before the pandemic, but with face masks and face shields.
Right.
In terms of surgeries, we pretty much do all the surgeries we used to do without any real restrictions. We used to do, COVID tests to make sure people don't come in with COVID going for the orthopedic surgery. But given, now the situation with most people vaccinated, the healthcare workers vaccinated, we didn't see that necessary anymore. So even that has, fallen as a prerequisite. But we certainly still do face masks on everybody. And I think we've learned to deal with it, and we, are pretty much doing our work like we did it before.
Yeah, that's exactly right. Just like in many sectors of society, it took months, but we figured it out, and care is safe and efficient now, which is fantastic. I'm shifting gears a little bit. For the audience here, I'll just let you know that all of us here, Dr. Schneiderbauer, myself, and my other colleagues, enjoy practicing in Vermont because we really feel that we practice in the patient's best interest, and that is the motivating factor, period. Whereas, in some other areas, there are other impetus in the way you practice. And I know that when I was interviewing Dr. Schneiderbauer, that was a big part of her thought process. So tell us how you work through with a patient, whether or not surgery is the right thing. I know you do a big surgery decision-making process, and patients are incredibly appreciative of that.
Yeah. I mean, it all comes down to history, really, in medicine. The key element is what the patient tells us. How long have they been struggling with that orthopedic problem? What have they tried, and what has maybe not been successful that was short of surgery? And if surgery is really an option to tackle the problem, that sometimes patients think surgery, with certain problems, surgery might be the option, but there's maybe not really a surgical solution to the problem, and that we have to discuss that too. But most things, can, be helped with surgery, like especially the arthritis issues when people have worn out joints, or if they have an acute break, or if they acutely tore a ligament, we can certainly help with that. One of the big questions is in the assessment is, do we have any kind of hope that the problem is getting better on its own, right?
Right.
Some things, if you wait a certain amount of time, they get better, but a lot of things do not. And if, physical therapy has been tried, people have tried some Tylenol over the counter and are still miserable, then surgery as an option is definitely more interesting to patients, because it is a process to go through. We understand that too as surgeons. We basically create an injury to your body to make you better.
Right.
That's not easy for a lot of people, and it wouldn't be easy for me to accept that either, right? I would have to kind of consider that a last resort in some ways, but with a good chance to get me better. And that's also an important aspect of the discussion. What are the expectations with the surgery? We have to make sure that what our patients think is going to be the ultimate outcome with that surgery, where they're going to be after they recovered, is matching with what we know from the literature. Is that really where they can get to? Those are very interesting discussions. Typically we can find a good solution.
So you sort of, in my mind, what you've identified is it's that the procedure is needed, that the patient themselves is ready for the procedure, both physically and mentally, that their expectations are in alignment with yours and what typically happens. And then there's that fourth component, that recovery part. Talk to us a little bit about that recovery part and what makes for a good experience with patients.
Yeah, what helps a lot is when patients, try to prepare themselves for the surgery ahead of time a little bit. There's going to be, some consideration is your home ready? If you, let's say, have a recommendation to use a walker initially after surgery for safety, is a walker problematic in your environment?
Right.
Or crutches? Do you have to climb stairs? Is there maybe a way to temporarily change your home around a little bit so that you don't have to climb stairs right away a couple of times a day? It will reduce the stress during the early recovery. And then how good are you with dealing with pain? Some patients struggle a lot, and they have, it creates a lot of anxiety when they have pain, because we try to do all the best we can with the help of anesthesia as well, with a so-called multimodal pain strategy, meaning to tackle the pain from all sorts of different directions to reduce it to the minimum amount. But there will still be some pain with surgery that is unavoidable. And some patients struggle more than others. And it's oftentimes good to have some support, like some people are by themselves. Some have, family support or friend support, which typically is helpful. So if you can recruit support for the recovery, that's good too. We have some people that tell their, children to come and stay with them a couple of nights after surgery once they get home. And that helps a lot, I think, reduce, anxiety, worries, and helps them, recover quicker and safer.
Yeah, so it sounds like not going into it blind, understanding all of the aspects, including that post-operative care, the time involved is so important. And I know you focused on that, as do your colleagues and your office. So can you, I don't want to put you on the spot here, but I get asked this all the time as a physician, tell me about one of the greatest cases you've had and what, the most impact. So let me ask you, you've been practicing for many years now. Do you have a case that you would share, or a type of case that really impacts you personally and makes you feel like you are excited at what you do and what you've gone into?
Yeah, I think that's a good question. I mean, so many cases or patient stories. Right. But I mean, it's, their lives and their quality of life. But one that certainly has stuck with me was a 17-year-old leukemia survivor that had early childhood leukemia that requires very intense treatment with a lot of, chemotherapy, bone marrow transplant, meaning their own blood producing marrow gets completely shut out and replaced with somebody else's, which requires full body radiation. The whole body gets radiated so that pretty much all the bone marrow gets killed. And that kid survived all of that, had it early in childhood. But the unfortunate side effect of that treatment was that his hip joints were completely destroyed. With the radiation. It can sometimes, shut off the blood supply to the hip joints, and they get destroyed. So that poor kid wasn't able to walk at all. Was getting around in a wheelchair and said, I can't even attend school. I want to, go to a normal school. I want to be a normal kid. I was asked to consider hip replacement surgeries on a 17-year-old, which is not the normal thing to do. For obvious reasons, we are worried about long-term, failure and possible revisions. But on the other hand, there was no way the kid was going to ever walk without something like that being done. The other problem with that was sizing, because that whole leukemia treatment also made him very small. So it required actually special implants to actually do it. That kid came back after he had the surgery, came back walking, said, I'm in school now, I'm, applying for university and all that, those kind of things, and was happy as a punch. And that will definitely stick with me, that patient history.
Absolutely. 17 years old and can't walk. That's just devastating. And to know that you intervened, but that we can do that and help those folks, is just a good feeling. So couple more questions here before we wrap it up. Just quickly, can you just tell the audience a little bit about, you do joint replacement, and one of the things that we talk about more recently is the same day joint replacement. Can you just explain that program?
Well, we've learned over the years that, years ago, people stayed in the hospital for 2 weeks after a hip or knee replacement or shoulder replacement. Then that became less and less time. We've, started now at SVMC the last year, also a little bit pushed by the pandemic, because people did not want to stay in the hospital necessarily. And we've also seen in the literature that it is definitely possible for some patients to go home the same day after these joint replacement surgeries. We've established a program here at SVMC and launched it very successfully with a good group of patients. So far, the patients who have gone through it are very excited.
That's great. And so I just want to thank everyone for joining us today. I want to thank Dr. Michaela Schneiderbauer of SVMC Orthopedics. It's been great talking to you. I'd love to have you back sometime, because we could keep going, do another 30 minutes on other aspects of care. I'll also thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, and Ashley Jowett from Southwestern Vermont Healthcare. Next week, I hope you can join me when I have Tom Haley. He's director of the Turning Point of Bennington. I'm so excited to have him speak to you and let you learn about all the great work Turning Point is doing in our community. And you can send your questions ahead of time on the website. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we'll see you next week.